Hello class, my name is Michael Schilling and today we'll go over the supervision of an athletic training student. This is for our signature choice assignment in kinesiology 750 athletic training pedagogical studies, and that's taught by Professor Jim Ave. Little introduction about myself. My name, again, like I said before, is Michael Schilling. I'm an athletic trainer and I'm an assistant athletic trainer at Stevens Institute of Technology, a Division III college in Hoboken, New Jersey. I received my Bachelor of Science in Athletic Training from Colby-Sawyer College, which is located in New London, New Hampshire. Today we'll go over a few things. We'll go over what is supervising in athletic training, why is supervision an important part of an athletic training education program, determining the correct special test or soft tissue tests to do on an injured athlete. This one will go over the ankle. We'll do a little analysis and then a summary of what we went over. Alright, so it's important to determine and understand what athletic training students have to go through now. In athletic training, the students have a minimum requirement. The minimum requirement is 2 years of academic clinical education. Most schools have you do it, have you start with an observation your sophomore year, and then you work your way into a clinical rotation junior and senior year. But it can differ and change a little bit depending on how the academics set up at that institution. What do you do in these clinical rotations? Gain knowledge and experience with different patient populations. This way you're not stuck at the same school dealing with the same people every time. You'll deal with new genders, levels of risk, contact sports. The college I went to didn't have a football team, so they sent us out. I worked rugby for Dartmouth College, and then I worked football at St. Anselm's College, a Division II institution. You also work with non-contact sports, soccer, and basketball, and then you can utilize the protective equipment in different sports as well. All students must be under the direct supervision of a qualified clinical instructor. These clinical instructors can be a certified athletic trainer, a physical therapist, a physician, an orthopedist, or a chiropractor. Any of these can work with the institution and the school to become a clinical instructor of some sort. Alright, next we're going to go over what is a clinical instructor. According to the NATA, an approved clinical instructor, or an ACI, is an NATA BOC certified athletic trainer with a minimum of 1 year working experience as an athletic trainer. This doesn't mean, however, that a physical therapist or chiropractor physician cannot be a clinical instructor. According to the NATA BOC as well, another qualified care professional with a minimum of 1 year experience can be a CI. Which role do an ACI or CI play? An ACI provides formal instruction and evaluation of clinical proficiencies in a classroom, laboratory, and/or in a clinical education experience through direct supervision of athletic training students. The difference between an ACI and a CI is that the ACI may grade the athletic training student. A CI teaches, evaluates, or supervises an athletic training student, but is not charged with the final evaluation of the students or their integration of skills and proficiencies, such as taping, evaluation. So they will learn, they'll be able to observe and go over things with them, but they might not have as much hands-on experience with these clinical instructors. Another important thing to look at is the educational reform that the Commission of Accreditation of Athletic Training Education, or CATE, has done the past few years. I know when I was graduating from Colby-Sawyer that everything was in the middle of changing. I graduated in 2011, and when I was a freshman, sophomore, junior, and senior, We were able to travel without the CI coming with us. I know that this is currently changed, and we'll go over some reasons why that this has changed. The education reform by Katie. Unsupervised clinical experiences are no longer acceptable parts of a student's formal education. This means that the student cannot use these hours that they've performed towards graduation. They still may be a first responder, first aid, using their CPR first aid certification. However, it won't count towards their athletic training. They've changed the terminology a little bit. It used to just be called supervision, but now that Katie calls it direct supervision. What is direct supervision? It is physical presence of the clinical instructor, allowing for visual and verbal contact with the ability for the CI to intervene on the behalf of the patient. This is important to realize as well. The student is no longer allowed to just go off on their own and do proficiencies. They're not allowed to go to the taping room and tape by themselves if they're not supervised by the CI or the ACI. The reason for this is a lot of the times the students were being another certified athletic trainer. They were getting used and abused in some points where they would work over hours and not be compensated for this, or they would go and not be proficient in a skill, and injuries may occur. So now they are required to be within earshot and be watched on everything that they do. Previously, direct supervision did not necessarily imply constant contact with the CI, but now they must be readily available for the students' ongoing instruction. This means that they are not allowed to go to a different part of the training room or in an accessory training room to do taping. Like I said before, unsupervised athletic training students can be first aid and CPR responders, but that's their limitations. Is direct supervision important? Supervision is important, and it can have a large effect on student growth and development. It can have good effect and bad effect. They can learn good aspects of athletic training from good athletic trainers. They can learn how to tape correctly. They can learn how to do correct assessments, but it can also have a negative effect. They can learn what not to do from athletic trainers. Some people, just use their students to do the grunt work, the paperwork, clinical notes, and they say it's a learning experience. However, they just don't want to do it. Without supervision, the clinical instructor would not be able to intervene if the athlete becomes unsafe. This is another reason why the rules have changed and why Katie has gone through some changes. There have been instances with athletes getting hurt, or that like I said before, that the athletic training student is not proficient in a certain taping or assessment of injuries. They might tell the student while they're in the accessory training room, "Hey, Mike, I hurt my leg and I don't know what I'm doing." And I tell them, "Oh no, you're okay. Let's ice it now and go practice," where they could have something more serious. Being available for athletic training students' questions if they're not in the direct supervision. How am I supposed to ask a question if I have one? If I'm the student, can I talk to the athletic trainer, the certified athletic trainer? I might have to call them. I might have to text them nowadays, but they're not there, and that can be dangerous. It's also important to work with the athletic training student one-on-one to develop more proficient skills, whether that is the special tests that we're going to talk about later, or taping, or small, just, the correct way to do things. All right, next up we're going to talk about NATA education competencies. This is the lesson plan that I put into place here. This is going to be clinical examination, According to the NATA, athletic trainers are educated and trained to perform exams on acute and/or chronic medical disorders. This means that in their ATEP, we learn how to assess injuries, both chronic and acute, subacute injuries that we would see in mostly athletes. We do go over some other injuries, but it's most of the injuries that we go over are going to be very common in the athlete themselves. Effective examination requires understanding anatomy and the physiological response to injuries. This means that we need to know which muscle runs where, what the movement is, the kinesiology involved, and it's important because it'll change the way the body reacts to specific injuries, and the reasons why we tape things the way we do, why we assess the joints the way we do, special tests. When you're testing a knee, doing the Lockmans correctly, making sure that we're going with the joint and getting a good read on those special tests. All right, the objective that we're going to be learning is CE 20E. For this lesson, we'll be testing the athletic training students' ability to use standard techniques and procedures for common injuries, conditions, illnesses, and diseases. In particular, we will focus on CE 20E, which I said before, which is selective tissue testing techniques and special tests. In this, we will mostly focus on the ankle, just different special tests and determining whether the student is going to be proficient in these tests. All right, let's set the scene here. For this, we will have a junior soccer player who is slide tackled on the field and stays down. The athletic training student and I are waved out on the field by the referee to assess the injury. The athlete describes a sharp pain along the lateral aspect of his ankle, and he felt a small pop. Athlete, after quick on-field assessment, is stable enough to be aided off the field. Pain is a 5 out of 10 on the pain scale, and the athletic training student will begin an off-field evaluation of the athlete under the direct supervision of the CI, which would be myself in this case. All right, what do we want to learn here? The athletic training student will perform a thorough evaluation of the athlete's ankle and demonstrate the correct soft tissue evaluations, techniques, and special tests. The student athlete will be able to decipher which special tests are necessary and which special tests that they may omit during this time. It is important that the athletic training student can determine whether they need to do an anterior drawer test or a heel bump test, squeeze test, which one we're going to rule out fracture, which one's going to have a sprain, which ligament is sprained, is it the ATFL, is it a peroneal strain. So it's going to be very important that the athletic training student talks his way through this and does each test correctly. The athletic training student will be able to demonstrate communication with the athlete, myself, the CI, and the team physician if necessary. The athletic training student will be able to list special tests necessary to determine if there's a fracture, sprain, or strain, and be able to determine which test is appropriate for each injury. Like I said, it's going to be important that they know that what the anterior drawer test is, how to do it, what it tests, and what a positive test would be. Same thing with a squeeze test, testing for a fibular fracture. How do I do this? Where do my hands go? What pressure do I apply? How long do I apply pressure for? What to do if the test is positive? How to splint it? So this lesson will start with the student taking a history of the injured athlete. During the history, I'd want to see the athlete do a thorough history, determine whether this athlete has ever had an ankle injury before, any fractures, and make sure that they haven't had any issues. I would supervise the athletic training student while a complete evaluation is performed, again maintaining that direct supervision that the NATA and Katie want to have at all times. During this time, or after the athletic training student, I would perform my own evaluation and compare my findings against the students. I would have the athletic training student ask any questions that they may have on the situation. That is important that they ask questions at all times. I might do something a little differently than they have ever seen, or that they do the way they do it. It's important to ask why I'm doing things that way. It's important for myself as a clinical instructor to ask the student, hey, why are you putting your hands there? Why are we taping this way? Why are we doing an anterior drawer at 20 degrees of flexion? Why do we have the ankle slightly inverted when we do the anterior drawer test? They should know that that's the way that you put the ATFL on a stretch. The next thing is we want to go to detail about what the difference in findings were, and offer suggestions to the athletic training student how to improve their evaluation and soft tissue techniques. I want to know that they know what they're doing at this point. I want to understand why they got a different finding. If I say, yeah, it's an ATFL sprain, but they're saying there's possible fibular head fracture. Why did they get that? Was there a positive squeeze test? Was there a positive bump test? Tuning fork? What are the reasons for that? If they have a good reason for it, then we will pursue the findings. But I do want to know why that we would get different assessments or differential diagnosis if we did the same assessment. I would conclude the lesson with a review of findings with the athletic training student. Like I said, I would determine why we came to either the same conclusion or a different conclusion. I would determine the differences in findings and discuss reasons why they may be different. Ask the athletic training student questions about why they did a technique a certain way, why their hands were placed a certain way. I'm a big guy. I'm 6'6". So I can do some special tests a little bit differently than other people. I get a little bit more leverage, especially with knees and hips, shoulders as well. So I might have a little bit different technique than, say my roommate in college was a 5'3" pitcher as well. So we did tests a little bit differently, but we ended up getting the same result just because we understood how the anatomy worked and why the body was done why it works the way it works. Then I would review the learning objectives individually and how the athletic training students can improve on these different objectives. All right, next we would go over the assessment. The assessment of the athletic training student will be performed when all the patients have left the athletic training room and after the evaluation is complete. The assessment would be an informal assessment with the ability for the athletic training student to ask questions about the whole evaluation process. It's going to be important to ask questions about every single part, and just not the soft tissue tests and the special tests, but history taking and subjective, objective, making sure they do the correct SOAP note at the end. Talking, I want them to be able to communicate with other healthcare professionals and understand why things are said the way they're said, and using the correct terminology for these. Make sure to point out if hand placement was correct or correct planes of pressure were applied during the test. That's, like I said before, you're not going to get a correct test if you do an anterior drawer and there is no inversion or flexion of the ankle joint. Just because the way the talus is going to glide, it's not going to put enough pressure on the fibular head and the ATFL. The CI will then indicate whether the athletic training student has the skills required to be competent in ankle assessment. The athletic training student should have already taken the class, special test class, the assessment class, anatomy as well, but can they combine all of this? It's not just a practicum, it's on the field assessment now, and that will make it a little bit more difficult to combine everything together, and for the athletic training student to be successful, they have to apply everything that they've learned into on-the-field assessments. Well, the effectiveness of this lesson, direct supervision of the athletic training student will substantially decrease the potential of incorrect decision-making or incorrect differential diagnosis. Without the athletic training student being certified, which some of them can be if they're a senior, it does decrease the potential of having someone file a lawsuit against you for negligence or having an athlete play when they're not supposed to return to play yet. Without the supervision of the athletic training student, they may make an incorrect decision about return to play or rehabilitation plans. Making sure that they're doing everything correctly, follow-up care is just as important as the first day when that athlete is injured. Providing feedback will allow the athletic training student to determine what to change in the evaluation process. They might not want to change anything. They might have done a great job, or you might do something a little bit differently and they say, hey, I like to pick that up. I know that I've learned a lot of different ways to kind of cut a little time out of the tests in general. I've been working the past couple weeks with 2 new athletic trainers their first years, and we had one of our athletic trainers left to go to another job, so now I'm working with 2 first years athletic trainers, and it's a little bit different. They don't know how to take the little shortcuts that are necessary. That being said, you don't want to cut out complete things, but continuous taping and taking a history, knowing all the red flag signs is something that they could learn how to do. Effectiveness in the clinical setting. Well, like I said before, this is the most important thing, is on the field assessment. Athletic training students will have the best experience in the clinical setting, allowing them to make decisions and not having scripted answers. When I was in class as well, our professor would give us a literal script, and we would have to memorize this, and it would be the history, it would be the special tests that we need to do, it would be everything that you want to do, and it would take a good 15 to 20 minutes to do an ankle evaluation. So having an athlete answer something that you might say, okay, ankle, he rolled his ankle, he's got a sprain, ATFL, most common sprain, but then the athlete comes and says, no, I rolled it, I had an inversion sprain, but it's all my pain's on the medial aspect of my ankle. Why would that be? I want the student to ask that question. Well, if it's an ATFL sprain, why do they have pain on the medial aspect of their ankle? Just to let them know that the tibia can come down and pinch soft tissue against the talus, and causing more of a deltoid ligament pain or just soft tissue pain in the area due to swelling. It's important that the athletic training students had experience in the classroom setting, learning the special tests for the ankle and lower body in order to become proficient as an athletic training student. It's the exact same thing I said before, pretty much. We just want to make sure that these athletic training students can be good students and good athletic trainers when they graduate. It's important that they can combine everything you learn and read in the textbook and bring it into a real life setting, not having a scripted answer, not having the athlete always say what you think he's going to say. Rolling around on writhing in pain is going to be tougher to get a anterior drawer test, heel bump test. It's going to be hard to get all of these special tests the way that they're taught in school. It's not easy to get any of the tests when the athlete is in in pain. Kliger's test for with external rotation. If they have any sort of deltoid ligament sprain, they're going to be writhing in pain when you do that. But the next thing is the clinical setting is important to an athletic training student to succeed. It's where the job is done. It's where athletic trainers are needed, is out on the field in the clinical setting. And being able to do this as a student advances their career immensely. All right, the final thing is the summary. It's direct supervision of an athletic training student is important in order for the student to develop good habits and skills. Not always are they going to pull all the good habits from an athletic trainer or this CI. They could be the best at what they do, but they may look at the little things that they did and they didn't like, so they might say, hey, I don't want to do something that way, whether it's a special test or just the way that they write their notes or the hours they put in. I know that I learned things that I didn't want to do when I was a student, or when I was a certified athletic trainer from when I was a student. Develop students' skills, good or bad. Let them determine what they want to take in the clinical setting when they graduate. Just like I said before, there are things that I learned that I won't do ever as an athletic trainer. But there are some things that I learned, different taping jobs, different methods of taping, different ways to do special tests, what special tests I can omit and I don't need to do if I'm 100% sure, that they didn't tear their Achilles. Is it important for me to do a Thompson test? No, I don't need to do a Thompson test. But it's always good to have in their arsenal to show them, to teach them that, hey, this is what a positive Thompson test looks like. If you have that Achilles rupture come in, make sure that you show the the student that this is what a positive test would look like. This is what a positive Kliger's test would look like. It's very important that they get the feeling of a Lockman's. If I was to have changed this entire project to a knee, making sure they know what a solid end field of an ACL feels like and what a lax ACL feels like with no end fill. Direct supervision is the most important aspect of learning in the clinical setting. This is one of the better things that Katie has done in the past few years, is allowing the student to get a better education. The one downside with that is not always does the student get the critical thinking aspect of things now. I remember there were times where I was left alone out on the field or sent to a room to do some taping, and athletes come up to you, ask questions. Maybe you don't know the answer 100% of the times, but it does make you think on your feet, and it's important as an athletic trainer to always be able to think on your feet. You never know what's going to walk through the door. You never know what injury you're going to see. So being out on the field, it's important that we are quick and thoughtful and understand why we're doing the tests we're doing and why we're putting the plan together that we have put together. And it's always important to ask questions. Asking good, solid questions, you can't go wrong. Why are we doing certain special tests and why are we doing them at that point? Is it good to, do every single test that we have in our arsenal? When do we do a certain test and not another test? As a student, you may not have all these answers. As a clinical instructor, you may not have all these answers. But when a student asks you that, it makes you go back and look at different things and look at why you're doing tests and other things the way you're doing it. Well, that is the end of my presentation. I hope you enjoyed it, and I look forward to all of the questions. If you have any, feel free to write it down on Moodle, and I will get back to you as soon as I can. Thanks, guys. Have a great day.